Good morning. My name is Alexander Gonzalez-Jacobo, and I'll be presenting on tissue oximetry as a potential alternative to ICG perfusion assessment in colorectal anastomotic cases. I have no disclosures. Inadequate tissue perfusion is one of the leading causes of anastomotic leak in colorectal surgery. Over time, there has been a myriad of technologies that have been used as adjuncts methods to assess bowel viability, such as fluorescence angiography, Doppler, spectrophotometry, and ICG near-infrared perfusion. ICG near-infrared perfusion has come to the forefront of intraoperative bowel assessment and has been clinically proven previously and is now becoming the standard for intraoperative evaluation of the bowel perfusion. This is a meta-analysis of 5 non-randomized studies, which included about 1,300 patients, and fluorescence imaging significantly reduced the anastomotic leak rate in patients undergoing surgery for colorectal cancer. Oximetry is another method that we use in the medical field. It's to assess tissue viability, and commonly seen is in the pulse oximeter, and it measures the ratio of red absorption of red light versus infrared light and the ratio of deoxygenated versus oxygenated blood. There are 2 types of sensors, the transmittance sensor and the reflectance sensor. The Introx technology uses a reflectance sensor, so that means that at the tip of the device, the first iteration is seen on your left, and the newest device is on your right. The sensor and the detector are at the tip, and it emits light into the tissue and picks up the light with the detector and determines a value. So our study was an IRB-approved multi-center trial. It was a non-inferiority study comparing Introx versus ICG angiography and assessment of bowel viability for colorectal surgery. Patients that were selected underwent large bowel resection for benign and malignant disease. The Introx device was used to scan the bowel and identify the oxygenated and poorly oxygenated bowel. Once the saturation margin, so we got a baseline on the patient's tissue, and we've designated a 10-point drop-off as the Introx margin. And then in the study, we used the ICG near-infrared technology with SPY-5 system to compare the Introx margin versus the ICG margin. And so this is a case that we did, laparoscopic sigmoidectomy, and it was exteriorized through a fan and steel incision. The clinical margin was selected, and the marginal artery divided. So proximal to this point, we would assume that it is perfused, and distal would be less perfused. So this is the Introx device. The sensor is at the tip, is placed on the bowel. So we obtain a baseline saturation, which for this specific patient was 75 points. And as you move down the bowel distally, you notice that it's decreasing in saturation. So we're looking for that 65 number because it is 10 points less. So, and as you can see, as you move further, we even get a value of 46 points. So then we come back, confirm our previous observation of 65, and then mark the bowel as the Introx margin. So then once this margin was selected, the ICG perfusion assessment was done intraoperatively of the same piece of bowel, and of note, they correlated. This process was done for every single patient of our study in the same order. 100 patients underwent minimally invasive colectomies and were enrolled at 2 centers. Of note, the age of the patient was, average age was 63, BMI of 29, and the majority of the patients were sigmoidectomies. The findings were very promising, that 92% of the cases had a decrease of greater than 10 points across the clinical margin and correlated directly with near-infrared imaging. When compared to ICG, the Introx device had a sensitivity of 96% and a specificity of 92%, with a positive predictive value of 89 and negative predictive value of 97.1. In the 100-case series that we did, there were no leaks that were reported and at 4-week follow-up or significant complications. In conclusion, the Introx device reliably identified a significant saturation drop-off that's correlated to near-infrared perfusion assessment. Although no conclusion can be made regarding the prevention of leaks, our data does suggest that the tissue oxygenation may represent an appropriate surrogate for bowel viability. And the Introx device showed may be a more cost-effective, highly portable solution for surgeons that does not require injection of dye, and it is repeatable to provide an adjunct to assess bowel viability intraoperatively. Thank you.